Hello all. Today I have recorded the small for gestational age fetus GTG. This is GTG number 31 and this is a very confusing GTG actually, because when you read it, some are limited evidence, some are moderate accuracy, some are mild accuracy, some are recommended, some are not recommended. So somehow we are not able to gather all the points at a time. So I'm sure this will help you in exam because this is a favorite topic and always there is a question from this topic in the exam. So let us start. And the good thing about this GTG is I have combined it with the TOG of Doppler study in the pregnancy. So that will help you in understanding the Doppler also well as sometime if you get the picture questions in exam, which is increasing nowadays, you will be easily able to diagnose it and answer the questions easily. So let us start with SGA GTG first, and then we will compile the TOG with that. So if you see small for gestational age, what is the definition? If you see, it is less than 10 centile of effective fetal weight or abdominal circumference. So estimated fetal weight or abdominal circumference should be less than 10 centile for the definition for the diagnosis of SGA. And it should be less than third centile to tell it is a severe SGA. Sometimes they can simply give you in the question in exam that she's 50th centile. So that is normal. Anything between 10th to 95th centile is normal, because less than 10th centile is where we will label her as SGA. So you have to understand that this centile is very important for you sometime to understand in the question that is it SGA or not. If anything more than 10 centile, for the estimated fetal weight or abdominal circumference, and you will not label it as SGA. Sometimes they will give you previous pregnancy, she had the baby 50th centile. So that means she was not having SGA in the previous baby. So this is the significance of knowing this centile. If you know it, you can diagnose that is it SGA or it is not. So less than 10 centile is SGA and less than third centile is severe SGA. So when you label it severe when it is less than third centile. Now, usually in our common practice, we use the term IUGR or fetal growth restriction. That is the term we use. But that is not same as small for gestation age. It is not same because when we are using IUGR, we are using it as a pathological one. And SGA, when they are using, SGA means small baby, which could be constitutionally small or it could be abnormal. So it could be physiological or pathological. That's why this is not synonym. IUGR or FGR is not synonym of SGA. All the IUGR baby will be SGA, but all the SGA baby will not be IUGR. That is what we have to understand. 50 to 70% of the SGA are constitutionally small. Sometimes even in question they have asked you this, that how much of the SGA is constitutionally small. So if you see more than 50%, almost 70, if you see 70% means quite high, they are constitutionally small. That means that is not significant. They don't need excessive monitoring. The outcome will be good because they are constitutionally small. That is not pathological. So we don't have to do much intervention in that case. This percentage is really important and you should remember it. Now, risk factor for SGA. This table is very, very, very important, because the problem is too many factors and we are not able to memorize it in a go. And then in question, they will give you minor factor because you are looking for more than 3 minor factor or you are looking for 1 major factor. So memorizing this table is a big task. So today I'll tell you how to memorize it easily by pairing it, which two things are looking same and you can easily memorize it. So whenever you try to memorize this table, always memorize the major risk factor first. Because major risk factor, if you get one only in the question, that is enough for you for the surveillance for SGA. That is enough. So no need of looking at another factor. Once you get one major risk factor, you are done from the question. You are going to monitor the baby. You are going to monitor the baby by MRCOG Doppler. That all surveillance tool we will discuss later. So let us first memorize the risk factor. So if you see major risk factor, maternal age. As we see, the age is a very important factor. More than 40 years if women is, then all the difficulties increase. The risk of abortion increase, there will be more SGA, there will be difficult labor, there will be more chances of cesarean, everything. There will be chances of stillbirth. So the age is very important. So age more than 40. If they give you 41-year-old women, then no need of looking for other minor risk factor or other previous history. That is enough for you. More than 40 years, very important. Then they will give you her personal history. She is a smoker or non-smoker. So if they give you smoker, if it is 11 or more cigarettes, then it is then you have to do surveillance. It's a major risk factor. So age and cigarettes, these two things. And then you have to understand other personal habits like cocaine. They will give you if she's using cocaine, if she's doing daily vigorous exercise. This daily vigorous exercise we will usually forget because we never give it too much of importance. Vigorous exercise is something you have to keep a note. So age, smoker, cocaine, and daily vigorous exercise. These all are her personal things. Then you will ask her the history. So in the history, if paternal SGA or maternal SGA. If you see father was also an SGA baby or the mother was also an SGA baby, then this baby is at risk of SGA. Paternal, maternal SGA, you can remember together. Then you can remember previous SGA baby in that mother, if she's a multigravida, previous SGA baby or previous stillbirth. This go hand in hand. Previous stillbirth actually is having the highest odds ratio for the SGA. Previous stillbirth has the maximum risk. This is very important and these two go hand in hand. If previous SGA, then the risk is twofold to get this time SGA. That is also an SBA question. So you have to memorize these two together. You have to memorize paternal, maternal SGA together. And these four things in her personal history. Then comes the disease history, the medical history. What other diseases she has. If she has any medical illness like chronic hypertension, she has diabetes with vascular disease, if she has renal impairment, if she has antiphospholipid syndrome. All of this, if you see, it is going to affect the vessel or kidney effect. So these all are going to affect the placental supply, and that's why it is going to lead to SGA. So these four things come from the medical history. Then in this pregnancy, you have to look for heavy bleeding similar to menses. We usually ignore this point. Heavy bleeding similar to menses. The same we ignore daily vigorous exercise. So this is important. If pregnancy-associated plasma protein A less than 0.4, even this is recent exam question. If it is less than 0.4, then you have to monitor her for SGA. This is important. These two are her history in this pregnancy. In this pregnancy, she has heavy bleeding. In this pregnancy, she has PAP-A level of less than 0.4. In this pregnancy, she has large fibroid. Definitely, if large fibroid, then symphysiofundal height measurement, which they usually do for screening, is not going to be effective. So you have to go to the next step, which will be umbilical artery Doppler. Large fibroid, because size cannot be measured per abdomen. BMI more than 35, because your findings won't be accurate. Or polyhydramnios. So these are the things where you are not able to monitor the women externally by symphysiofundal height or abdominal palpation. So you are doing the umbilical artery Doppler. So this one thing is enough. As I told you, major risk factor, one thing is enough for you to monitor the mother with the umbilical artery Doppler. That is a major risk factor. Now in minor risk factor, you have to understand the age again. This will be more of personal things like maternal age more than equal to 35. So if more than 40, it is major, but if it is 35 or more, it will be minor. If she is having an IVF singleton pregnancy, IVF pregnancy assisted conception when they give you in question, that is also minor risk factor. Whenever the age is more, whenever she's conceived with IVF, whenever she is nullipara, this triad go hand in hand. Definitely if her age is more, any difficulty in pregnancy is conceived with IVF, nullipara, it is minor risk factor. But you have to understand that not necessarily all IVF pregnancy will be nulliparous. Sometimes for secondary infertility also she can do IVF. So never assume that all IVF pregnancy will be nulliparous. That is what the mistake most of the time students are doing. If they have not mentioned in the question she's nullipara or not, then don't consider it as a nullipara. Age, IVF pregnancy, nullipara or multipara. If she's multipara, you have to see her previous pregnancy. They will give you in question that the baby is 6 months old, less than 6 months old, like 2 months, 3 months, 4 months old. Or they will give you that the baby is more than equal to 5 years old, either 5 years or more. Both these things we never take into account that this is also important. As nullipara is important, the same way multipara and the age of previous baby is important. Usually we will miss this while reading. Sometimes what happens? When we read the question, we get carried away. So some things we will be missing easily. So age is very important. We saw the type of pregnancy is very important. She is nullipara, important. If she is multi, what is the age of baby is important. To get these 3 risk factors, you are going to monitor her. So you have to look for the minor risk factor. If there is 3, you are going to do the uterine artery Doppler in your second trimester scan when you do for the anomaly. So that is the significance of minor risk factor. Then in personal comes the BMI. BMI less or more, both are not good for SGA. If it is less also, she's weak, she will develop SGA. If it is more also, 25 or more, then also she will develop SGA. You have to remember. Now smoking, we have seen more than equal to 11 goes to major. But if you see 10 or less, it goes to minor. You have to remember these difference of smoking. Low fruit intake is something we never care about, like we never care about daily vigorous exercise and heavy bleeding. Same way, low fruit intake, we don't care. So low fruit intake is also important. You have to memorize that. Previous preeclampsia. Here she has the medical disease this time. But this is the history. She has previous preeclampsia means she has difficulty in placental flow last time. Placental establishment was not proper. So again, this can repeat. Preeclampsia can come back again, but not surely. It is not going to be 100%. So it is a minor risk factor. So it's very important that you memorize all this. My suggestion to you all is at least write it down 1 or 2 times. If you write it down once or twice, it gets imprinted in your mind. Writing is very important. Believe me, writing things will give you more clarity sometime. When you read, you will miss it. But when you write, it will imprint better in your brain. Try to memorize this. This is a very important chart because whenever they ask you about the risk factor and how you are going to monitor the pregnancy, look for the SGA or not. These factors has to be by heart to you. Am I clear about this chart now? Okay, great. Now, risk factor in current pregnancy, if you see, we have already seen heavy bleeding. We have seen that she can have unexplained APH. The other important aspect is when you will be doing second trimester scan, you will be seeing echogenic bowel. Later pregnancy, she can develop preeclampsia. She can develop severe pregnancy-induced hypertension. She can develop abruption. So these all can develop later. As well as unexplained APH is also a major factor like heavy bleeding. Echogenic bowel is a major risk factor in the scan. Low maternal weight gain. This is very important because we always miss this. Low maternal weight gain is something we are not going to care about. So low maternal weight gain. The significance of it comes in nausea, vomiting of pregnancy, GTG also. Say if the weight gain is less than 7 kg, then there are chances of SGA. So very important to memorize this. Sometimes they will give you only this factor. She has low maternal weight gain. And that is enough for you to monitor the baby by umbilical artery Doppler. That's why all these factors out of which are only major are really, really important to memorize. Now, what are the tools for screening? This is very important. What all tool you will use and what you will not use. So tools for screening, if you see, most important is umbilical artery Doppler. This is what we do with one major risk factor. Or uterine artery Doppler, what we do with 3 minor risk factors. Or customized symphysiofundal height. Customized means the specific one. Like these are the factors for which you will customize. If her height, weight, parity, and ethnicity is different, her baby weight also will be different. Like if her BMI is more, her baby will also be more weight. If she's a multipara, the baby will be more weight. If she, for some ethnicity, like some ethnicity group are more tall, more heavier, so their baby will be bigger. So you have to customize your symphysiofundal height. If you will not customize, you will mistakenly tell it is a more or less or something like that. So customized word is very important. Never ever choose in exam simple SFH. Symphysis fundal height, always the word customize you have to choose with the SFH. And this should be done from 24 weeks. The weeks of gestation also is very important in SGA, because in options they will give you 24 weeks, 22 weeks, 20 weeks, 28 weeks, whatsoever. So you have to memorize that it is from 24 weeks. Customize SFH chart from 24 weeks is what you are looking for. Height, weight, parity, and ethnicity is the customization factor. Sometime in SBA, they will ask you this. What are the factors you are going to consider for the customization? It's also important to memorize. Now, if you see uterine artery Doppler, it has to be done 20 to 24 weeks. This is from 24 weeks because anything more than 24 weeks, we tell them it is stillbirth. So we are worried for more than 24 weeks baby because that baby can survive. So you are doing this measurement of SFH from 24 weeks. While uterine artery Doppler, which is for screening because of the 3 minor risk factor, you will be doing between 20 to 24 weeks. Why it is so? Why 20 to 24 weeks? Because that is the time, usually 20 weeks, 18 to 21 weeks is the time you will do your anomaly scan. You can do at the same time the uterine artery Doppler. But you can do up to 24 weeks. So 20 to 24 weeks. This range very important. This 24 weeks very important. And umbilical artery Doppler at 26 to 28 weeks. Because 26 to 28 weeks is the time where baby is definitely going to survive with a good neurological outcome. 28 weeks, they say, is a very good. So they're monitoring from 26 to 28 weeks. So this weeks of gestation is must to remember. You have to remember that these are the only 3 tools which you are going to choose in the options. Never ever choose anything other than this. Either it will be SFH for screening, or it will be, if there is a risk factor minor, 3 minor, it will be uterine artery Doppler. 1 major, it will be umbilical artery. No risk factor, SFH. That you will be doing for everybody. So this is what you have to memorize, that only 3 tools for screening. So what you will not do, that is also important. You will not do abdominal palpation for screening. Only SFH. Usually in our clinical practice, we do abdominal palpation, but that is not reliable. They say only 30% of the cases it can detect. So definitely it is not going to be a reliable thing. So abdominal palpation, you will never choose in exam for screening of SGA. Uterine artery Doppler in first and third trimester, you will never choose. They will confuse you by saying that uterine artery Doppler in first or third trimester. You know that it is 20 to 24 weeks. You will never choose this. Repeat uterine artery Doppler, never choose in the option. They will confuse you saying that uterine artery Doppler was abnormal. So now what you will do? So they will give you an option, repeat uterine artery. If uterine artery Doppler is abnormal, you are going to monitor by umbilical artery. You are not going to repeat the uterine artery. So that is an important aspect, that repeat uterine artery has no significance. In first, third trimester has no significance. And abdominal palpation has no significance in screening of SG. So these options never ever to choose. Am I clear about this? Because this is really, really important. Okay, my dear. Excellent. Thank you. Thank you, my dear. Now, screening, as you see this chart is utmost important. The risk factor we have already memorized. Now, if 3 or more risk factor you find, then you will do the uterine artery Doppler. If it is normal, what you will do? This is the most confusing question, and most of the time students make it wrong. If it is normal, will you leave her? You will not leave her, because still there is 1% risk of SGA. So you will assess the fetal size and umbilical artery Doppler in third trimester. One time at least you will assess by the umbilical artery Doppler. This is important. This they ask in SBA. If it is normal, what next? So next is to assess the fetal size and umbilical artery Doppler in third trimester. If it is abnormal, there is 32% risk of SGA. So if it is abnormal, as I told you, you are not going to repeat your uterine artery Doppler, but you will be doing serial assessment of fetal size and umbilical artery Doppler from 26 to 28 weeks. this is what you have to memorize. For major, one itself is enough for umbilical artery Doppler. So you will do like. Now, what are the present pregnancy risks? We already saw present pregnancy risks. PAP-A less than 0.4. This is a recent exam question. Fetal echogenic bowel is also a major risk factor. So this is at the time of anomaly scan. And this is at the time of third trimester. Severe PIH, preeclampsia, unexplained APH, and abruption. So if they mention one of these, you are going to monitor by umbilical artery Doppler. If they mention PAP-A or echogenic bowel, you are going to monitor by umbilical artery Doppler. This is what you have to memorize about this child. Now, for diagnosing SGA and IUJR, you are going to do AC and EBW. If it is less than 10 centile, you monitor the baby. You have to understand again here, it will be a customized fetal weight reference. You are not going to use same weight reference for all. It will be also customized. And two measurement, you will never do less than 3 weeks. Because if you do less than 3 weeks, there will be more chance of false positive. Usually what happens in private practice, if you see, some women, if they find less than 2 weeks, like 2 weeks lag, which is usually acceptable, still they will repeat the scan within 2 weeks. Within 2 weeks, measuring is going to give you false positive because baby weight might not increase that much in that 2 weeks. So they say that whenever you want to do it, you should do it at least 3 weeks apart. So you will get a correct idea that what is going on. If it is a normal baby, if it is not an SGA baby, then you will do at least 3 weeks apart. That is what you should look for the growth of the baby. Never do it before 3 weeks because that will be false positive. Never choose in the option that for a low risk baby. What investigation you will do in the second trimester? This is also important because if you get severe SGA in 18 to 20 week scan, that is something worrisome. Either the baby is structurally abnormal, chromosomally abnormal like karyotype, or infection. These three are the things which can make small baby at the 18 to 20 week scan. Because usually that is also sometimes we are relying for the dating. That means that is very accurate scan. If we don't have 10 week scan for dating, usually we rely on this scan. So at this time, it is not affected by the growth of the baby. It is usually reliable for the gestational age. It is coming small at that time. You have to be careful because if they give you at that gestation, you will choose the option of referral to fetal medicine specialist for detailed fetal anatomical survey and uterine artery Doppler. So that is that pregnancy finding for which immediately you are going to do the uterine artery. This is important. Then they sometimes will give you that before 23 weeks, if you are getting severe SGA, what you will be doing, karyotyping and structural anomaly, you have to look. You'll screen for CMV and toxo because these are the infection related with severe SGA. Mind the word severe. This is all related to severe SGA. That means less than third centile. But mind the word severe. They have to give you word severe. Otherwise, don't confuse with simple SGA. It should be severe. Syphilis malaria will be done in the area where it is high risk, like the endemic areas for malaria and syphilis in developing country, it will be more. So where the risk of syphilis malaria is more, there you will check for syphilis and malaria. The exam question is incidence of chromosomal abnormality in severe SGA, which is 19%. Incidence of fetal infection in SGA is 5%. So you have to have an idea how much chromosomal abnormality you can find and how much infection you can find in SGA. So this is also very important because if they give you second trimester SGA, then you have to think about these three things: structural anomaly, karyotyping, chromosomal abnormality, and infection, CMV and toxo. Okay, now prevention of SG. Sometimes they ask you what you can do to prevent. This is what they have asked in, I think, recent exam also, how you will prevent. So for prevention, only low dose aspirin and stop smoking is recommended. Low dose aspirin nowadays is 150 milligrams. So you will give that less than equal to 16 weeks if she is at risk of 2 moderate risk factor or 1 high risk factor for preeclampsia. And you will stop smoking by 15 weeks. This is what they have asked. Stop smoking by what week? 15 weeks or what? So stop smoking by 15 weeks is important, and low dose aspirin less than equal to 16 weeks. These are the only two things you are going to do for prevention. So what you will not do? Don't do dietary modification, progesterone and calcium, bed rest and oxygen therapy. So never choose this in option. These are not recommended. Only two things are recommended for prevention of SGA. Now, once you are doing the fetal surveillance, you will be doing umbilical artery Doppler, right? So they ask you, umbilical artery Doppler, what is the benefit? The benefit is it will decrease IOL rate, it will decrease CS rate. So it will be helpful for the pregnancy, mother, as well as the outcome. Then they ask you how you will time the delivery. To time the delivery in case of preterm and term, this is their favorite question. This is the most important slide because this is the favorite question, how you will time the delivery. Because all this monitoring you are doing to time the delivery at the right time. So to time the delivery in preterm, always you have to choose ductus venosus Doppler. Never ever choose BPP for the preterm. Never ever choose alone AFI, alone CTG, never. So always and always you will choose ductus venosus Doppler to time the delivery in case of preterm. And if it is term, means more than equal to 37 weeks. If it is a term baby, to time the delivery, you will decide it upon if it is an abnormal umbilical artery Doppler or it is a normal umbilical artery. If it is abnormal umbilical artery, the next step is ductus venosus. Always ductus venosus you are going to choose. But if it is more than 32 weeks with normal umbilical artery Doppler, then you have to choose middle cerebral artery Doppler. This is also very tricky one and they want you to know this. That's why they always ask, if normal umbilical artery Doppler, how you will time the delivery? If more than 32 weeks, you are going to use middle cerebral artery Doppler. If less than 32 weeks, you are going to use ductus venosus Doppler. If abnormal umbilical artery, next step will be ductus venosus Doppler. This is very, very important. This chart is really, really important how to time the delivery. Now, as I told you, alone CTG, alone AFI and BPP in preterm, these are you are not going to use because alone this is not going to carry any significance. And BPP in preterm is high false negative. So you will not choose it in option. Now, this chart, management chart, this is very important because whenever they make an EMQ or SBA, EMQ mainly will be made from this chart because how you will manage different scenarios. So you have to understand that whenever the symphysis-fundal height is less than 10 centile single or serial measurement is indicative of IUGR, in that case, the next step will be fetal biometry. Believe me, I cannot emphasize it enough that fetal biometry step is very important. Sometimes we will miss fetal biometry and directly we'll go for Doppler. The first step is fetal biometry. And this is what they always ask, that if you get any of these, if you get high risk for SGA, like according to history, according to biochemistry, which is PAP-A less than 0.4, or uterine artery Doppler is abnormal, then first step will always be biometry. In practical or in all practical application also, if you see, you never do umbilical artery Doppler without checking AC and EBW, right? Estimated fetal weight and AC is your first step. You will check first all the measurement, and if you find it small, then only you will do umbilical artery Doppler. Biometry is always the first step of scan. So whenever you find any risk factor like SFH less than 10 centile or any high risk, you always choose the next step of biometry. Once you did the biometry and you find again either single less than 10 centile or serial measurement of IGR, then you have to do the umbilical artery Doppler. This is your most important surveillance tool. Now in umbilical artery Doppler, if it is normal, if it is raised, or if it is absent flow, accordingly your management will differ in three categories. So first we will see normal. If umbilical artery Doppler is normal, then you have to do scan fortnightly, means every 2 weeks. Every 2 weeks you have to do AC and estimated fetal weight and umbilical artery Doppler you have to do every 2 weeks. And middle cerebral you will be doing after 32 weeks because we have already seen if umbilical artery Doppler is normal, then you have to time the delivery according to middle cerebral artery. That's why you are doing this after 32 weeks. After 32 weeks, very important, because accordingly you are going to time your delivery. Delivery, when you will do delivery, though baby is small, baby is not normal, baby is small, and umbilical artery Doppler is normal. So ultimately the baby's IUGR and the Doppler is normal. So you're not going to allow her to continue the pregnancy beyond 37 weeks because there is no benefit and more risk. So you will offer delivery by 37 weeks for her. Offer delivery by 37 weeks. You will involve the senior clinician. You will recommend delivery by 37 weeks if middle cerebral artery PI is less than 5th centile. So this is what you will time the delivery according to middle cerebral artery. Consider delivery for more than 34 weeks if static growth for 3 weeks. This is also important. As I told you, you will not do scans uh, less than 3 weeks because you can get false positive. So if you are doing the scan 3 weeks apart and you are not seeing any growth, she is more than 34 weeks, then no point in waiting. You can deliver her. You will recommend steroid if you are delivering by CS, very important point, because in options, they will give you sometimes CS without steroid cover, CS with steroid cover, IOL or CS. So this category, you will be delivering her by normal delivery. So IOL is a good option. You will not choose CS for a normal Doppler. You will never choose CS for a normal Doppler. So this category is always IOL. This category where the umbilical artery Doppler is normal and you are planning delivery, it will be IOL. Now, if it is abnormal, if pulsatility index or resistance index is more than 2 standard deviation, but end diastolic volume is present. So if it is abnormal, but not that bad, absent flow is not there, at least end diastolic volume is there. What you will do? You will do repeat ultrasound weekly, which will be AC and EBW, and you will be doing twice weekly umbilical artery Doppler. Twice weekly umbilical artery Doppler. Earlier, you have seen in that category, you have done fortnightly. Now, in this category, you are seeing you will be doing twice weekly. So that is the difference. The delivery plan will be same. You will be delivering by 37 weeks. You will consider steroid and you will consider delivery if it is static growth more than 3 weeks. You will recommend steroid if you are delivering by CS. So this is also important. This middle category is also very confusing. How frequently to do the Doppler. So you will be doing twice weekly Doppler. While in first category, you did fortnightly Doppler. Now this is the last category, third, absence or reverse flow. You will refer to the fetal medicine specialist. If it is absent or reverse flow, you will be again doing the scan weekly for ACVW. And now you will be doing daily Doppler. Here you saw fortnightly Doppler, twice weekly Doppler, and now it is daily Doppler. So daily Doppler you will be doing for umbilical artery Doppler and ductus venosus Doppler. Because time of delivery, you know, time of delivery will be decided by ductus venosus whenever umbilical artery Doppler is abnormal. So ductus venosus Doppler you are going to do. And in some center where the ductus venosus Doppler is not available, you can choose computerized CTG. In computerized CTG, if short-term variation less than 3 milliseconds, then you will deliver the baby. So when you will deliver the baby, recommend delivery before 32 weeks if abnormal DV Doppler. Or if abnormal DV Doppler is not there, means only umbilical artery Doppler is abnormal, but it is maintaining in that level. So you will deliver by 32 weeks. So when you will deliver before 32 weeks, abnormal DV Doppler. By 32 weeks, umbilical artery Doppler abnormal, but DV Doppler is. So this is how you will time the delivery. This is very important for you to understand because sometimes they will give you more than 24 weeks, EBW more than 500 grams, and DV Doppler is abnormal. So if it is more than 500, you will plan the delivery. But if it is less than 500, the baby survival is very low. So they will not recommend delivery. That is what they meant to say. That's why they have put this criteria of weeks and weight. By 32 weeks, you will deliver all whoever has absent or reversal of flow. And you will consider delivery at 30 to 32 weeks with senior opinion. So that factor you have to memorize. If DV Doppler is normal or abnormal, accordingly you have to plan your delivery. This is all about this chart. This is really, really important chart. And if you see what you are expecting in 2 weeks, so AC should increase by 1 centimeter and EBW should increase by 200 gram in 2 weeks. 100 gram per week, like that you can memorize. 1 cm in 2 weeks is what they mean to say. So this chart, if you remember, most of the question of SGA you can answer, because according to risk factor, they will give you one question scenario is surveillance, how you will do the surveillance. And the other is management. So definitely you have to know the management. You have to understand that whenever you are choosing CS, you have to choose steroid because you are doing delivery. Whenever you are doing CS before 38, before 39 weeks means 38 plus 6 weeks also if you are doing, you have to give them steroid. So always choose the option with steroid. Never choose without steroid in cases of CS. But in normal delivery, no need of steroid. So this is important factor. Sometimes they confuse you by not giving you steroid in the option. Whenever there is absent or reverse flow, always CS. In these two categories, you have IOL option. But in this category, there is no option of IOL. Always has to choose CS with. This is an important aspect to memorize. Okay, so now if you see the mode of delivery, I already told you in the middle two category, you can do IOL. So with normal Doppler or with abnormal Doppler with EDV present, you can do IOL. And with absent or reverse flow, always CS with steroid. Early admission is also important because you have to do continuous monitoring because the emergency CS risk is 15%. These all percentage I have given you so that you understand that absent or reverse flow CS rate is almost 75 to 95%. So no point in trying. So if you remember, if you have an idea about this, you will never forget that CS is very important for absent and reverse flow. So mode of delivery is very important. They will, whenever they ask you management question, they will always ask you mode of delivery. Now, we have already finished the GTG, which is very, very, very difficult because the very confusing scenario and you don't grab a point after reading that GTG. So now after this, if you read your GTG, you will really feel more confident. Now I'm explaining you the Doppler ultrasound talk. This is 2015 talk and a beautiful talk. This will help you in your clinical practice also, as well as an exam. This is going to be very good. So this will help you in understanding the diagram questions also, as well as we have discussed here what is absent, reverse. So what does it actually mean in the scan? If you understand that, it's easier for you to memorize. So here is the first one. This is the umbilical artery Doppler. If you see the normal waveform, this is the normal umbilical artery Doppler. This is the diastolic flow. So when they say end diastolic volume is present in the second category, means it is present here. When they say absent and reversal, this is what they mean where we are doing CS. So this is here, you can see that diastolic volume is absent. And here you can see that it is reversed. So this is the important, most important Doppler flow, umbilical artery Doppler, to time the delivery and to do the surveillance for the baby. Now, if you see, they say that this absence or reversal, this goes in this flow chart. If you see first, there will be umbilical artery pulsatility index more than 95th percentile. Then it will affect the MCA less than 5th percentile. Then absent flow, then reverse flow, then ductus venosus abnormal PI more than 95th, and absent or reverse A wave in ductus venosus, then pulsatile umbilical vein, then CTG abnormality, and then finally acidemia and stillbirth. So this is the sequence of event. Now, if you see, this is the ductus venosus flow. This is the A wave of ductus venosus flow. So if absent A wave or reversal of A wave, then it is abnormal ductus venosus, and then you will deliver any baby, term or preterm, all the baby will be delivered according to the ductus venosus flow. So this is the best predictor of acidemia. Now this is a uterine artery flow. If you see, this is the uterine artery normal flow. This is systole and this is diastole. So this is what you're looking for, notch, diastolic notch. So This is the notch we are looking for. If notch is there, that means it is abnormal uterine artery Doppler. This is all about all the pictures. If they give you any picture now, you will feel more confident and you won't be shaky about how to choose the treatment now for the SGA patient. Now here is my introductory session on 12 at 3 p.m. GMT. And these are the topic. This is my number. If you have any doubt regarding SGA or any other thing, you can message me. And join me for this session so that you get the idea about my upcoming course for the July batch. This is my course feature for the July batch, which you can go through, and we will be discussing it in the session. This is my Telegram group link. You can join it so that we can discuss daily. Daily, we are discussing module-wise question answers. Any doubt you have a schedule to follow, everyday reading, so that all helps in your preparation. This is the Facebook group link. All these links are available in the description of YouTube channel. So through that, you can join the group and be part of the study in the group.